VMR, and we have with us Dr. Dhaliwal here with us to discuss a case today. And I think I'll just pass it over to Dr. Dhaliwal to talk about himself, and then we can go ahead with the case. Yeah.
Perfect.
Welcome.
Thank you, Brody, for that introduction. Thank you, everyone, for making the time to join wherever you are in the world. We already did a little bit of a round robin of what the time of day is for everyone. It's 3 p.m. here in San Francisco, and I'm delighted to spend this hour with everyone. I think I was just mentioning at the top of the hour that what we do here is amazing, right? We sort of unpack the thing that goes on inside our mind and try to externalize it so that there's a huge multiplier effect. So instead of one person having a conversation in their mind, this conversation is happening with dozens and dozens of people. And I think that's what I really love about clinical reasoning, is that it just spreads knowledge way beyond what happens inside one person's mind when we put this language and mindset to it.
Awesome. And here, what I love about VMR is we have people from kind of all different stages in their clinical training. So is there any advice that you could offer kind of people as they begin this clinical reasoning process?
Yeah, I could hardly offer better advice than what's embodied in the clinical problem solver, because I think it gets at the essence of it, right? That you try to put yourself in front of as many cases as possible. Then you try to acquire knowledge from other people, but not just what they know, but why they think. And you sort of mix that in a stew, and it's mix and repeat over and over again. That's the ingredient. It just here, the formula has already been created. So I would only say keep up a practice routine, and you'll be on your way to success in this regard.
Awesome. And then we have a
Travis hit on one. I must say, Travis hit in the chat on one of my secrets as well. In fact, I just logged into my Human DX app the other day just to check something in the settings, and I realized I've been at it for like 6-7 years, as long as it's existed. That whether your daily practice is VMR, your daily practice is reading a case, or your daily practice is logging onto an app, something every day is the key to it.
And then VMR and this learning could not happen without our wonderful case presenters. So I'd like to also welcome Madalena, who is a medical student. Would you unmute and introduce yourself?
Yes, hello everyone. My name is Madalena Conti. I'm currently a third-year medical student at Zucker School of Medicine at Hofstra in New York. I'm currently in Los Angeles visiting my partner here, and I'm super excited to present a case and very excited to be here.
Okay, well, let's get this clinical reasoning party show on the road.
Okay, great. So for the first aliquot, and I know that, Brody, I think I sent the case to your email, but you still hadn't received it. Is that right?
Yeah, but that's okay. I think I'll do it on the slide.
Well, if you need me to repeat any details at any time, just let me know.
Yeah, thanks. Yeah.
Okay, great. So for this aliquot, I'm going to start off with just the chief concern and the first part of the HPI, and then we'll pause for discussion. So the chief concern in the patient's own words is, I have a headache. And in terms of the HPI, so this is a case of a 40-year-old female with a past medical history significant for genital HSV and recurrent migraines, presenting now with persistent headache and nausea for 1 week. So she was in her usual state of health until about 1 week ago, when she reports the gradual onset of a generalized headache and nausea. Ibuprofen provided only mild relief, so after 3 days of symptoms, she presented to an urgent care. At this urgent care, her temperature was measured at 100.1 degrees Fahrenheit, and after a workup, she was ultimately discharged with the diagnosis of acute viral syndrome. However, since discharge from this urgent care 4 days ago, her headache and nausea have worsened, and she now reports fatigue, at least one episode of non-bloody vomiting each day, neck pain, and light sensitivity. She denies any sick contacts at home or recent international travel. She does report that she traveled from her home in Queens, New York to Eastern Long Island for a winery tour 10 days ago, but she denies any tick or other insect or animal bites during that trip. And that's the end of the first aliquot.
Okay. So I think that, there's so many different threads you could pull out here. I think the major one, or the major problem that we're contending with, is headache. And then all of the other things that may factor into it, such as nausea and fever, light sensitivity, all those other things are circling it. But it's important to elaborate what our approach is for headache, and everyone may have a customized approach. I think one that's very useful in urgent care and clinic is the separation of primary and secondary headaches. For the most part, primary headaches don't have a strict neuroanatomical correlate, but they have a syndrome that's associated with them. So migraine, trigeminal cephalgias, and tension headaches dominate in that category. And there's many features here that are compatible with migraine, so we'll have to examine that. That's the diagnosis she carries. And then there's all the secondary headaches, which oftentimes, if they're unchecked or untreated, pose a risk to neurologic function and sometimes life. So we spend a lot of time making sure those aren't present. And those are infections like encephalitis, meningitis, and there are cancers, primary and secondary, that arise in the CNS. Rarely there's autoimmune phenomena that might unfold in the brain itself. There are vascular phenomena that can do it, whether they're bleeding or thromboses. So all of those warrant our attention. She carries a diagnosis, I think, Madeleine said, of migraines in the past. Is that correct?
Exactly. She's had recurrent migraines in the past.
And I think because even though we're at a unknown case conference, I think you have to ask yourself, what about this is consistent with it, presuming that is the correct diagnosis. And there's many things here that are compatible with migraine. One is that it's a recurrent problem. That's a characteristic of migraine. The second is it might bring fatigue, that it might have light sensitivity, that it might be precipitated by something like a viral syndrome antedating it, and that it might have nausea associated with it. All of those things are very compatible with a migraine. So if you wanted to say, make that the null hypothesis just on the version of base rate, you'd have to say, what about this doesn't fit for it? And if I really had to say, the thing that doesn't fit for it would only be that the fever is ongoing now, and so that maybe points me to one of the secondary causes that I mentioned. But otherwise, it's quite good. I'm actually going to look at it and say, why wouldn't I say this is a migraine? She might tell me things that are important, like this isn't like what it's been before. Most patients of a migraine have a relatively repetitive pattern that they endure. It's different from the next person, but that may be one thing. And then finally, we'll look to see if she has any past medical history. The only thing we know about her now is that she has HSV. HSV is so common that you have to wonder, will it be signal or noise? There is a way that someone could get recurrent infections related to HSV that overlap with headache, but we'll probably come to that later. The converse is to reject the migraine hypothesis and say, what's a really serious hypothesis that we raised? And one that comes to mind quickly is meningitis, because I can just rearrange all the things that were written there and say, there's a 40-year-old who has headache, neck pain, photophobia, and nausea, which may signify raised intracranial pressure. And that sounds like meningitis, which might be of a viral or bacterial etiology. So I think just like in all things, the capacity to hold two different scenarios in your mind at the same time may be the best way to approach it.
Wonderful. Okay, so moving on to the second aliquot. So in this aliquot, I'm going to give you a review of systems, family history, social history, and the physical exam as well. So on review of systems, as I mentioned, she reported fever, headache, photophobia, and neck pain. She denied any chest pain or palpitations. She also denied any shortness of breath, cough, abdominal pain, or diarrhea. She denied any dysuria, any skin changes, rashes, and joint pain. So in terms of more details about her past medical history, as mentioned, she has a history of genital HSV. She denies any active lesions in the genital area or mouth at this time. She mentioned that the last flare-up was about 3 months ago, and it's unclear if she manages this with any medications. In terms of her recurrent migraines, she gives, when asked to elaborate, she said that these occur at generally irregular intervals of time, generally a few times a month. She says that she generally experiences sensitivity to light during these migraines. She also states she does not take any consistent medications, and she says they often self-resolve or improve with ibuprofen. She said she's never received a lumbar puncture for her migraines in the past. In terms of past surgical history, she received a dilation and evacuation 3 months ago due to trisomy 21 that was that was noticed on kind of genetic analysis. For family history, she reports that her mother has hypertension and her father has heart disease. She did not elaborate beyond that. For social history, she was born in Queens, New York, and currently lives in the same area with her 2 children, her husband, and her mother-in-law. She's functionally independent, works as a stay-at-home mom, and has 1 bulldog in the house. She denies tobacco or IV drug use, and she reports to drinking 2 to 3 drinks per week socially. She reports regular sexual intercourse with her husband, who is her only sexual partner. She engages in oral and vaginal sex, does not use protection, and reports no concerns in sexual function. She does not take any medications regularly. She just reports some allergies to iodine and neosporin, where she develops a mild rash. So in terms of vitals and her physical exam, in the ED, her temperature was measured at 98.9 Fahrenheit, her heart rate 94, blood pressure 168/118, respiratory rate 20, statin 99% on room air. So in terms of her general appearance, she is well appearing, alert, oriented to person, place, and time. She did not appear to be in acute distress. For HEENT, her nasal and mouth mucosa were clear with no signs of thrush, no tonsillar erythema, ulcers, or any lesions. Her eye exam, extraocular muscles were intact, no drainage or redness. Her cardiac exam was normal rate and rhythm, S1 and S1 sounds were present, no murmurs. Respiratory, breath sounds were clear and equal bilateral. GI, abdomen was soft, non-tender, no guarding. For her MSK exam, she did have some mild bilateral paraspinal tenderness to palpation, no midline tenderness, and no nuchal rigidity, just some tenderness when you palpate. The range of motion was intact, but she did just endorse the neck with mild pain. In terms of her neuro exam, she was alert and oriented, as I mentioned. Cranial nerves 2 through 12 were grossly intact, and there were no focal motor sensory deficits on the exam. And that's the end of the second aliquot.
And her thinking was clear in terms of conversation and answering questions.
Yeah, great question. Her thinking was clear. She was just in general distress, and in that moment she had kind of this migraine that she was endorsing, and also some sensitivity to light, but she was conversational and speaking clearly.
Okay. Sensitivity to light is interesting. Again, I think the way this case is interesting is having one hypothesis that there is an infection, a viral infection or non-specific infection that has set off her stereotypical migraine. And the second is that's an incorrect formulation. And this is something more serious like meningitis. And I'm going to continue entertaining them. But just so we mentioned sensitivity to light, since you mentioned it, it's a very interesting finding because it's not a characteristic of many diseases. It's certainly a feature of meningitis because we learn about it for photophobia. It's also a very characteristic feature of migraines, just like phonophobia travels with photophobia. And then probably the ocular disease that has the most associated with the issue is uveitis, where the constriction of the pupil is difficult to tolerate. But those diseases in particular, light is particularly bothersome. And so that, while it's capturing my attention, I still want to go through the other points that were raised here. So I think, she has a fever again, and the formulation that she had a viral infection NOS that set things off was very reasonable. But now that we've examined her, it's not clear where that virus is, right? We don't see a respiratory viral infection. We don't have history or signs of a GI viral infection. She herself is not localizing it in any way. Sometimes there's an overlap between the two. There are acute viral infections that are quite serious that cause meningitis. A great example of that is acute HIV. And that's something that we might be thinking of as we move towards a meningitis of one type or the other. But I think given the things that we see here, which is fever, photophobia, neck discomfort, and it need not be rigidity. Sometimes that's a very late sign. You're starting to see enough signature to say that meningitis is likely present, but encephalitis isn't. Encephalitis means that the encephalon, or the brain, isn't functioning normally, and hers seems to be intact in terms of all of cognition that we're working on. And then going back to sort of the situational things or the history things she has, I think someone was asking about the dog, the bulldog, and I don't know if we're going to pin things on the bulldog or the kids or the husband. All of those are potential vectors in this person's life. Children certainly can bring run-of-the-mill enteroviruses back home if they're in their school setting, et cetera, and then that could be spread to her. She's monogamous with her husband, but we'd have to confirm through history taking that the husband is monogamous as well in order to assure ourselves aren't a risk of a STI. And then her past medical history is intriguing. She has genital HSV, which is very common by seroprevalence studies, less common in terms of suffering outbreaks, but she seems to have recurrent episodes. Her last one was 3 months ago. And it is conceivable that the HSV, which is breaking out in a mucocutaneous way in the genital region, sometimes can affect the CNS. There's a syndrome called Mollaret's meningitis, where the HSV is found cutaneously, but also shows up in the CSF. So that's one consideration that we may tie the two together, but we don't want to jump to that because it's just a common condition. Regarding her migraines, if we think this is a meningitis and we get to that point through LP, we may go through a very standard analysis of lymphocytic pleocytosis. And so that'll get us to think about infections and occasionally autoimmunity or malignancies. But one thing to remember is that there are some drugs that reliably cause meningeal irritation. And one of them is ibuprofen. I shouldn't say reliably, but it's on the list of things that causes it. So is it conceivable that she has a headache and actually what we're seeing is a toxicity or a meningitis that's coming from excessive NSAID intake, which someone may be prone to do if their meningitis, or sorry, their headache isn't responding. So I am pleased that her cognition is intact. I'm pleased that there's no neurodeficit, but I'm still not reassured that there isn't a CNS infection in the form of meningitis. And I think if I can just indulge one more, this is a dilemma we oftentimes have in the ER, which is patient has a history of X, they're coming in with X, and our question is this just another version of X, or is this a complete deviation? It's something else. And headache is a prototype. If someone comes in with a migraine, we wonder, is this their migraine again, or is this a secondary headache coming in on day one? And I bet that was the dilemma they were contending with here.
Yeah, that's a very fascinating question. As you're saying, when someone has a history of migraines in this case and presenting with very similar symptoms, how do you kind of change the path you're going down to explore if it's something different or just another presentation of that?
Right.
Quick question for you. What types of tests would you get, after doing this physical exam, and how would you think about doing an LP versus not?
Yeah, I think in terms of basic tests, I think given that we have an inflammatory syndrome here, right? There's a fever with systemic symptoms, thinking about infections, primarily, less so autoimmunity or malignancy with just 1 week's time is going to be the dominant consideration. So I think a CBC and Chem7, rather non-localizing to be honest, but just that they give us some profile of the patient. How we're doing the platelet count also useful if we're going to decide an LP. And then really going back and saying, is there any reason to think that I might do more specific ID testing? So we can do non-specific testing, like a respiratory viral panel, although she doesn't have respiratory symptoms right now, an HIV test. But remember, if we want acute HIV, we have to send the PCR at this early stage or a P24 antigen. She took the trip to Long Island, and if she goes further along the eastern seaboard, is it conceivable that there is a tick-borne illness? Because even though she doesn't remember having been exposed to a tick, it's completely conceivable that she would have been, or she doesn't remember the bite, she might have been exposed to it. Testing at this early stage, one week out, for things like Lyme, Ehrlichia, Anaplasma is unlikely to yield positive serology results. So I may resist that unless there's a much stronger signal like cytopenias or transaminase elevations that would make me think those are worthwhile. So I might, in practical terms here, I might just get a CBC, Chem7, perhaps a viral panel because the spectra of viral illness has been raised. Consideration of an HIV test, history around tick-borne illness, but probably not testing for it right in this moment. And then I'd look at those lab tests, but I'm not sure I'm going to be able to talk myself out of doing a lumbar puncture. Even though I might be expecting maybe perhaps viral meningitis compared to bacterial meningitis, because this is at a bit more of an indolent course.
Got it. Okay, great. So moving on to the third aliquot, which will give you some initial labs and imaging. So her CBC was within range. Her white cell count was 6.6, hemoglobin 13.6, hematocrit 41.8, MCV 97.2, platelet 278. Her chemistry panel was also unremarkable. So the sodium was 139, potassium 3.4, chloride 102, bicarb 23, BUN 12, creatinine 0.79. A beta HCG was also sent, which was negative. A urinalysis was also obtained. The appearance was clear, light yellow. It was negative for protein, nitrates, and leukosterase. Negative for bacteria as well. In terms of imaging, a chest X-ray was also obtained, which was clear. A CT of the head was obtained, which was negative for intracranial hemorrhage, mass effect, or midline shift. And lastly, an LP was also obtained. And the CSF opening pressure was 32. 8 milliliters of fluid was obtained. And now for the spinal fluid analysis and gram stain, so the total nucleated count was 220. Per CSF percent lymphocytes was 89%. CSF monocytes 11%. Red blood cell count 8. Protein was 63. Glucose 46. LDH was 23. The culture that came with these initial findings showed no growth, and the gram stain showed no organisms were seen, only polymorphonuclear leukocytes. And that is the end of the third aliquot.
Okay, let me just study through that. I think I didn't mention they got a UA and chest X-ray. There was no localizing symptoms, but I think that was very reasonable. Certainly the kind of basic tests that are done before we commit to an LP. I just wanted to study the LP myself.
Yeah, let me know if you want me to repeat any of the values.
You don't happen to have a differential in the CBC?
Oh, let's see. I can pull it up on the EMR. I didn't write it down in my notes here, but I can definitely pull it up on the medical record.
I think I missed that. Yeah, Madeline, could you just repeat that part, I guess?
Oh, yes. So the white cell count was 6.6, hemoglobin 13.6, hematocrit 41.8, MCV 97.2, platelets 278.
Hold on. Okay, just a sec. Like I think 1 minute. I think MCV was 47. You said
MCV was 97.
And then what else? Okay, what was the differential? I guess that's probably more important.
Yeah, I don't have that in my notes here, but I can pull up her chart and check for you.
So while that's coming up, I'll at least begin my analysis. I think for the most part, this looks like a common profile of a lymphocytic pleocytosis or lymphocyte dominant meningitis. And I'm going to use the word meningitis partly because the CSF and partly because the syndrome is meningitis. It's headache, photophobia, neck stiffness or discomfort, but not encephalitis. There's no cognitive dysfunction to speak of or deficits that we're aware of. So I'm putting a pin in one finding, which is the CSF of the opening pressure being 32. Is that correct? Did I hear that right?
Yes.
Is there an elevated opening pressure? Okay.
Exactly.
That's a little bit distinct from most, but not all causes of lymphocytic pleocytosis, but I'll come back to that because I don't want that to be the dominant feature. Like that could be a variation in technique. It's a single number, but the rest of it warrants a standard approach to a lymphocytic pleocytosis in the CSF. And I think it's the categories of diseases everyone in the VMR community is familiar with, which is infections, autoimmunity, malignancy, drugs, for the most part, are really responsible for that profile and probably roughly in that descending order. So the infections that can do this are all of them. You know, we tend to think of bacteria being neutrophilic, but partially treated bacterial infections will be lymphocytic. Some bacterial infections even have a characteristic phase where they're lymphocytic, like Listeria. Sometimes there's a bacterial infection that's parameningeal, so it's not in the meninges itself, and so you'll see lymphocytes instead of neutrophils. But I don't want to dismiss bacterial infection just because something is lymphocytic. But the headliner by far and away are viral infections. when someone does have a lymphocytic pleocytosis. And sometimes there are ones that we can find the name for. So, they can be things like HIV, HSV. There's a little bit of red cells there that might make an association with the encephalitis version, not the meningitis version. West Nile virus, the enteroviruses. Those are examples of viruses that we might find in the CSF. Mycobacterial infections can do that, and they oftentimes have a very high elevated protein, which is only marginally here. Fungal infections can do that, rickettsial diseases, and spirochetes. So you can sort of go down the entire spectrum of the 5 or 6 major categories of infections, and all of them are candidates. But before you sort of lock in on infections, you do have to just remind yourself that you can have autoimmune disease show up as a lymphocytic pleocytosis. Examples would be lupus and sarcoid. Malignancies can also do that. If you have a lymphocytic or carcinomatous meningitis, that also can give you a predominance of lymphocytic cells. And then, as we mentioned at the get-go, if we found this was an exposure to a medication, and 2 common ones are NSAIDs and Septra, and recurrent or persistent exposure to them can also give a lymphocytic pleocytosis. So I step back and say those are the categories, but because I was worried going into this about infection, I'm going to maintain the focus there first. And say which one of those categories seems likely. I think the idea of acute bacterial meningitis is less likely, given that we don't have neutrophilia. I said it's plausible, but it's still less likely. This is most compatible with a viral infection, and we mentioned one that she might be at risk for is the HSV, because it absolutely, when it reactivates in the lumbosacral plexus, also can reactivate in the CSF. That's the Mollaret's meningitis that was mentioned before. And then I want to touch on a category that I sort of passed on, which is fungal infections, because of that opening pressure, right? I think perhaps one of the syndromes that we see a lot as an elevated opening pressure is Cryptococcus. And if you want a really great tutorial on this, the Curious Clinicians podcast had a great episode. I think it must have been 2 or 3 months ago, where they say, how come Cryptococcus, but not all other fungi, typically have these really high opening pressures? And I can't do it full justice, but I think the gist of it was that the polysaccharide capsule in Cryptococcus clogs up the arachnoid villi in the brain and obstructs CSF drainage in the way that histo or blasto, if it's in the CNS, doesn't quite do that. So that's the origin of why crypto has this association with a very high pressure. Oh yeah, someone's bringing it up, and there will be much more. It's really a great episode, because I love the image that they created, and also the explanation that they had. So I think we have to, different doctors, I will say, have different profiles. Some people, if they are thinking of viral meningitis, still cover bacterial meningitis until the cultures come back negative, and that probably relates to risk tolerance or epidemiology. Other physicians say, I'm confidently not in the bacterial category, and I'm okay watching or treating as if this is viral. And I think those are both defensible stances in a case like this. I don't think she's given us a signal of bacterial meningitis right now. I've lost the whiteboard, but then my screen.
Okay, great. And I have the differential now. So for the CBC, so the neutrophil percentage was 69.4%, lymphocyte 22.6, monocyte 6.2, eosinophils 0.9, basophils 0.6.
I'm sorry, I missed the was that the serum WBC, or that was the
exactly the serum?
Okay,
serum.
So that was more.
Yep.
So
another question I had is that, well, any other questions on repeating any of the data or anything?
I've just lost track of the whiteboard. Is that me, or is my view, or is the shared screen now the Curious Clinicians?
Brody, I think you have to put news.
Sure.
It was a great plug for them. It looks like an infomercial.
Yeah.
Commercial is like plug right in the middle of this episode. I love the cross-platform plugging of each other. It's awesome.
Yeah.
So yeah, I think it was raised in the chat, if I saw it go by. I think we do have to think about like what would sort of get covered, as it were, and that becomes just that same thing. It's just an exercise in going through the 5 or 6 principal categories of disease and deciding if there's a reason to cover a bacteria, a virus, a fungus, a mycobacteria, a spirochete, a rickettsial disease, a parasite. I mean, it's a very familiar path that we go on. Those categories, by the way, aren't they're not the, you know, the kingdom or phyla that we learned in bacteria or biology class, right? Those are, I think that's a much more constrained thing, but those ones we just elaborated are the much more functional ones that clinicians know. Like technically mycobacteria are part of bacteria, if I understand correctly, but doctors don't think that way because mycobacteria have different epidemiologies and drugs and behaviors, and spirochetes are the same thing. Technically, they're under the bacteria category. So that's why I elaborated sort of the 6 or 8 that you wind up thinking through if you're in an uncertain infectious disease situation.
Interesting. And so another question I had is, you know, given these LP results, would you start empiric treatment, or how would you think about just initial management in the ED setting?
Yeah, so I think I have to sort of go through the thought process of those categories. I think, I mean, I'd have to look at her. I'm not sure I would start. Yeah, I'm not sure it's such a profound lymphocytic, because I think she needs to be monitored. She's not doing well. She's febrile, she's got a headache, she's got nausea. So I feel she's going to be admitted. I think I'd probably have to look at her. I'm 50-50 on whether I would give antibiotics at this time, but I think categories that would be a little more compelling would be giving an antiviral because of the HSV. We don't have a GU exam, so I forget if there's an active outbreak now or not. And then also, so thinking about acyclovir fundamentally, and then whether we consider a rickettsial disease because of the travel recently to Long Island. I said tests may be inadequate 1 week out, but that doesn't mean that a pathogen might have not made its way through the CNS. It's very early for Lyme disease to affect the CNS, but I can imagine Ehrlichia or Anaplasma, maybe in an aggressive way, sort of reaching the CSF this early on. So it might, you could consider an unusual cocktail here, like acyclovir and doxycycline, for instance. But you could also add the standard treatments if you wanted for bacterial. Although really the provision of vanco and ceftriaxone, she doesn't, I don't think she warrants ampicillin, would maybe feel like overkill, but I certainly probably would do it in 50 days, 50% of the time.
Got it. Okay, great. So this will be the last aliquot of information before the.
Can I ask, by the way, the GU,
Yeah.
I don't know if a GU exam was done or not.
So I found this patient a little bit later, but a GU exam was not done, but she said that she did not have any active lesions.
Okay.
At least a GU exam was not documented when I was reviewing her initial admission.
But just
Exactly.
an outbreak, you know, if it's going on, would increase the probability substantially. The other thing just to mention is whether we would send testing for all those categories that we mentioned, right? You can, if you want, start to send the extended testing for fungal and mycobacteria, whether it's PCR testing, serologies in the blood, serum cryptococcal antigen. I think HIV testing is certainly warranted for the reasons that we mentioned. RPR, you can test all those at day 0. The fluid is there and is very valuable and hard to get. So oftentimes people will send those things at the get-go. And I think given that the scenario is not clear-cut, that would be reasonable to do as well.
Yeah, that's great. Okay, so I'll kind of share what she was given in the ED. So in the ED, she was given Reglan, so metoclopramide, Zofran, morphine. She was also given fentanyl, 75. She was given ceftriaxone IV. She was given vancomycin, acyclovir, and Benadryl. So those are all the things she was given in the ED. So for a little bit more testing, so HIV testing was done, which was negative. Blood cultures were also done, which grew coag negative staph epi. They sent a tick-borne DNA panel, which, you know, as you know, took a few days, but just for the purposes of the order of the case, I'll read now. So the tick-borne panel was all negative. So it tested for Babesia, which was negative, Anaplasma, which was negative, Ehrlichia, negative, Borrelia, which was negative, and Lyme serology also came back negative. So the CSF PCR returned, which will reveal the final diagnosis.
And again, I think how extensive we want to be on day 0. 1 point, if the HIV test is negative, remember that wouldn't exclude the possibility of acute HIV.
Right.
In fact, we might expect if it was this short an exposure, you could be HIV negative by antibody, but P24 or the viral load is positive. I think the tick-borne panel, we would just test ourselves to say if that's positive, do we believe it? And for instance, if there was a hemolytic anemia, it's sort of the company that it keeps. So if Babesia was positive and there's hemolytic anemia with intraerythrocytic forms, we'd say, I believe in that's Babesia. If there's bicytopenia and hepatitis, we'd say, well, anaplasma or ehrlichiosis seems more likely. If there's a recollection of, I did have a rash with central clearing or just a rash at all. I didn't know what it was a week ago. Then mine becomes more plausible. So I think all of those warranted consideration. The blood cultures being negative, they're positive in about 50% of cases of acute bacterial meningitis, but not surprising that they are negative here. And as that culture and this one comes back negative, fundamentally we have license then to pull off the antibiotics. But we're left saying, like, what is it that we're seeing today? And almost that existential ED thing I said before, like, are we seeing much of the same? Are we seeing a repeat version of something she's had in the past, or is today a new problem? And I think the pathogen that we really do want to think about is her recurrent episodes of HSV, and think about it perhaps in two ways. One is today she is having an episode of HSV meningitis. So this is not encephalitis, and it's very important to separate the two out. HSV1 encephalitis is a devastating condition. It's neuroinvasive. It comes with high morbidity. Acyclovir does its best to arrest it, but oftentimes leaves quite a bit of damage. HSV2, most frequently meningitis, is like a viral meningitis syndrome, which the patient is acutely ill from, but has a high chance of recovering. So one formulation is today is acute HSV meningitis, and that's the viral meningitis that she's suffering from. But one other thing is just going back to her past medical history that she has, which is that she has recurrent migraines. And there is an alternative formulation. Migraines are so common that one has to make sure that the migraine was assigned in a medical way. And by that, I mean, sometimes people self-describe themselves as having migraines, or conversely, a doctor uses it as a shorthand to say, oh, it's a headache that you get a lot, and I will call it a migraine. But that's one possibility. The other is that many of her previous bouts of headache may have even been HSV sort of in a subclinical way of affecting her and causing meningitis. If we went back in her history and she said, I actually get multiple episodes of my migraines, oftentimes by fever, oftentimes set by a viral episode, then you might say maybe what you're having is every one of these quote unquote migraines is actually a CSF HSV infection. And that is the Mollaret syndrome that I mentioned early on. But I want to make sure that I'm not missing some other epidemiologic link. If this was happening in California today, I might think about West Nile virus. And that's still plausible from her travel. So maybe the test that we need is a West Nile viral PCR in the CSF, or IgG and IgM in the blood. And I'm trying to think if there's anything else that I would lean on as I pick through the PCR. Yeah, I think that would be my thinking here in real time. I think that many viruses we can't separate among, but if you told me this winds up being an enterovirus, or this winds up being West Nile virus, or this winds up being HSV, all of them seem like they'd be very suitable. But maybe to tie in most to her past medical history, I might favor the HSV as the more likely pathogen in this case.
Incredible. Okay, so the CSF PCR returned positive for HSV2. And exactly as you said, it was thought that the recurrent migraines in the past, it was possible that those could have been, recurrent episodes of this, consistent with, as you said, Mollaret's meningitis. So fantastic job. So just a little bit of follow-up. So she was given 5 days of IV acyclovir, and it changed to PO Valtrex to complete a total of a 10-day course. And I actually just checked her medical record this morning. She's had a follow-up appointment, and her symptoms are improving with this. So fantastic job discussing that.
Thank you. Marvelously presented. I think that the right challenges, it recreated the challenges of the providers, like each one of those decision nodes.
Yeah, exactly. I do have a few teaching points. I'm not sure if now's the time or if, yeah,
No, please,
okay.
Yeah,
Go ahead, go ahead.
Yeah.
Okay, so yeah, when I was involved with this case, I had never heard of Mollaret's meningitis, so it was really fascinating to learn about. So exactly what you said, first I kind of looked up herpes simplex meningitis. So as you said, it's a cause of viral meningitis in adults, generally caused by HSV2, which, as you mentioned, is in contrast to HSV encephalitis, which is generally caused by HSV1. We had a discussion about whether the genital lesions were present, and when I was doing some research, the genital lesions are present in approximately 85% of patients with HSV2 meningitis and can often precede the onset of CNS symptoms. However, the HSV meningitis can also occur, obviously, without the evidence of genital lesions, so it doesn't completely rule that out. Interestingly, the role of antiviral therapy I saw for HSV meningitis remains somewhat unclear. For hospitalized patients, generally you give acyclovir administered every 8 hours, which is the general recommendation I saw. And then as you discussed, there is the syndrome, Muller-Ray's meningitis, which is a form of recurrent lymphocytic meningitis characterized by these recurrent self-limited episodes of aseptic meningitis, which was likely the case for this patient. And in terms of presentation, I saw that there can be a lot of variability in terms of the time course. Generally there are signs and symptoms of meningeal irritation, fever, and some patients can have, these transient neurological manifestations like cranial nerve palsies. As we talked about, the most common agent is HSV2, and the diagnosis is generally made by PCR for the HSV DNA in the CSF. And yeah, so that's kind of the main teaching points I have, but amazing discussion.
Thank you so much. If I remember correctly, I think the advent of PCR was transformative in naming this. Like there was a syndrome, of recurrent lymphocytic meningitis of unknown etiology, but and that's pre-existed PCR. And when PCR became available, then they figured out that HSV2 was responsible for that syndrome. That's my recollection, because PCR is sort of 10, 15 years on the radar screen in clinical medicine. And I think it solved the mystery of why some patients would have a recurrent aseptic meningitis.
Interesting.
I don't know if you came across that in your reading or not, but I think that it shows how sometimes when we get new tests, then we can re-explain old phenomena.
Wow. Yeah, I didn't come across that, but I'll have to look into that.
I think there's a couple of things that are really interesting here, aside from the diagnosis and the journey this person on, which is, almost all complex cases wind up, you have to throw out something, right? And sometimes it's something super meaty. You're like, oh, this has got to be part of the final solution, like a blood pressure of 170 in a previously healthy 40-year-old person, or in this case, a CSF opening pressure that's, 50% above the normal range. And I don't have a good explanation for it, but it oftentimes there is something where you're like, sometimes it is so profound, there's no way it can't be part of the final answer. Like, platelet count of 10. Platelet count of 10 will be part of the final answer of whatever syndrome is someone has. But then there's other things that you recognize are both on a spectrum and they're susceptible to measurement error or just radical variation. And I think those two things would definitely be fair to describe blood pressure as, and even CSF measurement as. And maybe that's what happened here, and whether it was positioning for the CSF opening, because I also don't have an association with viral meningitis causing this high a pressure normally, but it also doesn't seem like it's impossible to think of.
Yeah, that's fascinating. That's fascinating.
So Dr. Dhaliwal, I wonder, reflecting back on the case, if you could say 3 things that learners should take away from this case.
I think, I think one of them, probably the first one, was the ability to hold 2 scenarios in your mind simultaneously, so not jump to whatever came to mind. So for instance, in some ways, Madalena was presenting, it was painting a picture of meningitis, but I also wanted to keep in my mind the infinitely more common fever and headache, which is exactly what they thought, which is like a routine infection sets off a previous headache syndrome. So the ability to keep 2 things in mind, I think in parallel, was very helpful. I think maybe the second point that we mentioned, which is when we're trying to solve a case, it's rare that we can account for every single abnormality, and you have to be prepared to jettison, 1 or 2 things that don't fit, even when they feel like they have to be part of the final solution. And then maybe the third is to reflect on, what schema was most relevant or salient, like what's worthy of revisiting in this case. And I think, although you could revisit your illness script for migraines or your illness script for viral meningitis, and I wouldn't dissuade anyone from doing it, probably the schema for lymphocytic pleocytosis or lymphocytic CSF or aseptic meningitis, that's named all 3 of those things, would be the best one to revisit and relearn, and remind ourselves that many infections can do it, but also that there's a number of non-infectious things that can as well.
Great. And I actually have a question. It was actually mentioned in the chat by Herschel Hens. So when I was looking up Muller-Ray's meningitis, it was often said that sometimes, or these generally self-resolve, these episodes self-resolve, but sometimes it can be managed with acyclovir. And in this case, she was given acyclovir for that 10-day course. In your experience, how is it generally managed, or what are the reasons why it self-resolves versus other times you decide to treat it with acyclovir?
I think it is characteristic of it almost in the way that, if you think of an HSV outbreak in general, it's a self-resolving condition, sort of there's escape from the neurons, or, the neural ganglia where they exist, they escape, they appear somewhere, either cutaneously or inside the CSF, but then I think the immune system brings it back under control. Unlike HSV1 encephalitis, I don't think treatment is mandatory.
Mm-hmm.
I mean, it may be that it helps a little, or it may be that doctors can't resist once we have a bug. I don't know which one it is.
Yeah.
But it's not hard to believe that it's not transformative. Just like virtually all other treatments we have for viral meningitis, right? That most of those we also watch.
Right. Yeah, and just to echo what you were saying, I think one of the things I loved hearing when you were discussing this is kind of holding those two trains of thought in your head and not getting kind of attached or not getting attached to one diagnosis or train of thought, and just kind of holding these two options in your head and going with both as you get more information. That was really amazing to see. So thank you.
Because I think you want to imagine an alternate universe where you did an LP and it was totally normal, right? Like no one should feel like it was inconceivable that the LP would have, it may not have made it to VMR, but it would have been totally compatible with real life. Like I did an LP because I was concerned and it was normal. So I have to go back to my previous formulation. There was some viral syndrome and her migraine is flaring.
Yeah, exactly.
That's why you hold both of them in parallel. Yeah. There's some quote, I can't remember it, but there's someone that says something like the mark of a great mind is the ability to hold two competing thoughts in parallel. And I forget, some great literary person, but I don't know who it was. So maybe someone could look that up in the chat. The John Fitzgerald or the Scott Fitzgerald? Those are some remote neurons. I'm much more up on my lymphocytic meningitis than I am on my literary history.
Yes, it's Fitzgerald.
Okay, Fitzgerald. Yeah, that's what I thought. What is the quote exactly? Do you have it?
Yeah, it says the test of a first-rate intelligence is the ability to hold two opposing ideas in mind at the same time and still retain the ability to function.
Yes.
One should, for example, be able to see that things are hopeless, yet be determined to make them otherwise.
Love it. Timeless quotation. Thank you.
Yeah.
Andrea.
Awesome session, everyone. Thanks so much to the team, and thanks to Brody for scribing. Andrea, are you ready to take it away with teaching points?
Yes. So we started with a patient that had headache, and that made us think about if it was primary or secondary. Primary doesn't have a strict anatomy, and we think about that tension headache. In the case of secondary, we have to be very careful because if we check it, it can put the health of our patient at risk. So we can think about vascular problems, bleeding. The fact that the patient had an ongoing fever made us think about a secondary cause. And then we thought that the patient had meningitis because she had all the signs of the syndrome, that is headache, photophobia, nausea. And an important pair about sensitivity to light is that infection can set a stereotypical migraine, meningitis, migraine, and also the uveitis can cause a sensitivity to light. In the case of, and we rule out that the patient had encephalitis because her cognition was conserved. A little bit about moderate meningitis is an unusual syndrome of benign recurrent ascending meningitis, and it the causative agent is herpes simplex type 2 in the majority of the cases. And the current outbreak, if the patient has a current outbreak, it decreases the probability that it's a moderate meningitis, but the genital lesions present in 80% of the cases. And according to Dr. Gurpreet, it was called recurrent lymphocytic ascending meningitis before PCRs were available. Something new is that I didn't know that ibuprofen that we use so often can cause meningeal irritation. When we talk about Long Island and infectious diseases that can be transmitted by ticks. There has been Rocky Mountain spotted fever, tularemia, and Powassan virus. And if a patient has cytopenia and hepatitis, that makes us think more about anaplasma or ehrlichiosis. In this case, the patient in the CSF has lymphocytic pleocytosis that make us think about a virus like West Nile, HIV. It can also be caused by a partially treated bacterial infection, because normally when we think about bacterial infections, we think about neutrophilic, but that's something important to not rule out the bacterial infection right away. Also, listeria has a lymphocytic phase, and this is like lupus, sarcoid malignancy, and cause lymphocytic pleocytosis. And we learned that the cryptococcus has a capsule that is unique and makes it easy to extract the CNS. That's why they tend to present with a high opening pressure compared to the other microorganisms. And then in the migraines, it's always important to see if the patient was clinically diagnosed or if they self-diagnose themselves as having migraine, because in this case it's important because it was not a migraine. Thank you very much.
Terrific.
Thank you so much for those teaching points. I know it was a lot, but that was so clear. Thank you.
Thank you, Andrea.
Thanks, everyone. Have a good night.
Bye, everyone. Thank you, Madalena, for a marvelous presentation.
Of course, it was so much fun. Thank you.
Thank you so much, Dr. Gurpreet. See you guys.
Good night, everyone.
Bye,
Good
everyone.
night, everyone. Bye-bye.
Bye. Thank you.